in terms of management, it's more about now getting towards individualized concepts. So really looking at that patient in front of you, we're realizing that a lot of the trends that we're seeing for efficacy also relate to toxicity. So patients that have high LDH, high inflammatory markers, a high CAR hematox score, these are patients that are at higher risk profile for developing not only hematological toxicity infections, but probably also CRS and ICANS. I think that's really relevant. So I think if a patient now presents to CAR T-cell therapy, we're better at figuring out, is this a patient that needs more escalated supportive measures, for instance, prophylaxis, antibiotic prophylaxis, antifungal prophylaxis. This is a patient where we should give early G-CSF versus that low-risk patient where I think we can wait, because we have also learned that some of the measures that we're doing, such as antibiotics, they also have side effects. And I think identifying those patients that don't need these escalated supportive measures can also be relevant. I think both of them are sort of the same, or two sides of a coin, really identifying high versus low risk candidates. And then I think in terms of management of hematological toxicity in particular, one thing that I think has the last year or so has shown is that when a hematopoietic stem cell boost is available, and this is some work that we also published, if it is available, probably it makes sense to apply it as early as possible. At the same time, the survey results showed us that oftentimes it's not available. And I think squaring those two things, on the one hand, sort of if you have a high-risk patient, you have an available boost to give it. I think that's sort of a trend that we've seen for hematological toxicity in particular.